Good evening, students. Welcome to you from Sri Rama Hospital, Jagaipet. Today we are going to start the topic on disease of the thyroid. Thyroid is a butterfly-shaped endocrine unpaired organ situated in front of the neck. It derives its name from the word shield. Thyroid means shield because the original name for thyroid was for the thyroid cartilage. It looks as if it is a shield protecting the vocal cords inside or the voice box. Because this gland is anatomically related to thyroid cartilage, it is called as thyroid gland. Anatomy of thyroid gland. Theodore Cocker and Theodore Billroth pioneered the surgical management of thyroid disease in late 1800s. A thorough understanding of thyroid anatomy is central to the performance of safe thyroid surgery. Not only for the performance of safe thyroid surgery, but also to understand the disease of the thyroid, the anatomy is very, very essential. The gland is situated in front of the trachea. It has two lobes, one on either side of the midline, with the connecting isthmus situated about the second, third, and fourth tracheal rings. The lobes extends upwards up to the level of the thyroid cartilage. Just let us dissect the layers of the neck to see the position of the thyroid gland. This is the platysma muscle that is there in the subcutaneous tissues of the neck. Once we remove the platysma, then we will find the superficial veins. These are the anterior jugular veins, and here is the external jugular vein. And this is the communicating vein between the anterior jugular and external jugular. Some individuals you find only unpaired anterior jugular vein. And this is called the space of Barnes. What is space of Barnes? It is situated between the layers of general investing fascia of the neck. The deep fascia of the neck is divided into three layers. A general investing layer which invests circumferentially around the neck. Then one prevertebral layer. That means the fascia which passes in front of the prevertebral muscles. Then another one is the pretracheal fascia. The fascia which passes in front of the trachea. So these three are the parts of the fascia of the neck, the fascia of the neck. Fascia of the neck also, the fascia of the neck also is called as the collis fascia. So if you look at this, this is the general investing layer of the deep fascia of the neck. It splits to enclose the sternomastoid muscle. Then it passes behind. It splits to enclose the trapezius muscle. It is attached to the cervical spine posteriorly. It gives off two prolongations. One is the pretracheal fascia, the other is the prevertebral fascia. Both these prolongations occur at the posterior part of the sternomastoid muscle. Between these two prolongations lie the carotid vessel and jugular vein and vagus nerve. So these three structures derive the facial covering, and this facial covering of these carotid vessels, jugular vein and vagus nerve is called the carotid sheath. This prevertebral fascia passes in front of the prevertebral muscles. It is a tough fascia over which the esophagus and trachea lie. This is the esophagus and this is the trachea. Then this is the pretracheal fascia. The pretracheal fascia splits to enclose the thyroid gland in the midline. So the thyroid gland is situated deep to the sternomastoid muscle. Even when thyroid gland enlarges, it will never come in front of the sternomastoid muscle. So if you see any lobular swelling in front of the thyroid, in front of the sternomastoid muscle, it is not due to thyroid enlargement. That must be something else, not thyroid swelling. So a thyroid swelling always lies deep to the sternomastoid muscle. So usually the students will be under the impression that whenever they find a oval swelling in the front part of the neck, they think that it is thyroid. So you must see the clinical signs. It must be under this sternomastoid. That means at this portion it is exposed, but the lobe which goes behind the sternomastoid muscle. Once you remove the general twisting layer of the deep fascia of the neck, you will find the anterior ribbon muscles. I hope all of you know about these ribbon muscles. What are these ribbon muscles? Ribbon muscles are the front of the neck. They are situated in two planes. One is superficial plane, another is the deeper plane. What are the muscles that are there in the superficial plane? Superficial plane muscle is sternohyoid. Deeper plane muscle is sternothyroid and thyrohyoid. And what is this muscle that is there on the lateral side of the sternohyoid muscle? This also looks like a strap muscle, but this is not called a strap muscle. What is this muscle? You can see a pair of muscles. This is the anterior belly and posterior belly will be here. An intermediate tendon is present. So this is omohyoid muscle. Now you can see the sternohyoid stretching from the sternum to the hyoid bone. So the bones in the midline of the neck are the uppermost one is the hyoid bone, then the thyroid cartilage, then inferiorly is the cricoid cartilage, then inferior to the cricoid cartilage are the tracheal rings. This muscle stretches between the manubrium sterni to the hyoid bone. In the deeper plane, you find sternothyroid, that means sternum and thyroid, between sternum and thyroid. Then between thyroid and hyoid bone, that is called thyrohyoid. So there is sternothyroid and thyroid muscles. Then afterwards we find pretracheal fascia. The pretracheal fascia is attached above to the thyroid cartilages, thyroid and laryngeal cartilages. That means cricoid also. It extends laterally up to the posterior bond of sternomastoid, where it gets fused with the general investing layer of the deep fascia of the neck. So the thyroid gland, along with its vasculature, is enclosed in between the two layers of this pretracheal fascia. Now you can see the blood vessels supplying the thyroid gland. Once you take away the thyroid gland, you will find the tracheal rings. And here is the cricoid cartilage. You are not able to see the cricoid cartilage fully because it is enclosed by a muscle. This muscle stretches between the cricoid and thyroid cartilage, and this muscle is called the cricothyroideus muscle. And this is the shield-like structure in the thyroid cartilage. And above here is the hyoid bone. It has a greater carno and lesser carno, and this is the body of the hyoid. And between the hyoid and thyroid cartilage lie the thyrohyoid membrane. Thyroid contains two lobes connected by an isthmus. It is situated in front of the trachea, enclosed in between the two layers of pretracheal fascia. Hence, it moves on deglutition because of its enclosure in the pretracheal fascia, which moves with swallowing. The pretracheal fascia is attached above to the thyroid cartilage and cricoid cartilage, and it encloses the thyroid gland. During swallowing, the thyroid cartilage and cricoid cartilage, they move upwards. So when they move upwards, automatically the pretracheal fascia also moves upwards. So because of the movement of the pretracheal fascia, the thyroid gland also moves upwards on swallowing. What is the lower extent of pretracheal fascia? I told you about the upper extent up to the thyroid cartilage. Laterally, it is fused with the general investing layer of the deep fascia at the carotid sheath. Then what about lower extent? What is the lower attachment of the pretracheal fascia? Is it fused with the sternum and clavicle or to something else? That's very good. It encloses the thyroid gland and it proceeds downwards. It goes downwards behind the manubrium sterni. It is not fused with the, or it is not attached to the manubrium sterni. It goes downwards into the mediastinum, and there it gets attached to the pericardium, in front of the pericardium. This anatomical point is very important. Why? Because if thyroid gland enlarges, it enlarges in between the pretracheal fascial layers. So the thyroid gland can enlarge only up to the upper border of the thyroid cartilage. It can't go beyond that because of the attachment of the pretracheal fascia to the thyroid cartilage. Similarly, the pretracheal fascia is going behind the manubrium sterni into the mediastinum. So a thyroid gland which enlarges downwards can go down into the mediastinum. That is how you can see cases of retrosternal goiter. If pretracheal fascia is attached to the manubrium sterni, let us suppose, then thyroid gland cannot go down into the mediastinum. It will stop at the manubrium sterni. As the pretracheal fascia is going down into the mediastinum, thyroid gland also goes down into the up to the mediastinum. And the pretracheal fascia arises deep to the sternomastoid muscle. The thyroid gland always lies deep to the sternomastoid, however large it may be. Pretracheal fascia extends into the superior mediastinum. Thyroid can also extend into the superior mediastinum if the gland enlarges downwards. Blood supply. You can see the thyroid gland here, the blood supply. This is the carotid artery, and this is the subclavian artery. The carotid artery divides into two branches at the upper border of the thyroid cartilage into the external carotid artery and the internal carotid artery. So here you are not able to see the internal carotid artery because of the internal jugular vein presence here. So internal jugular vein is superimposed over the internal carotid artery here. The common carotid artery has no branches in the neck. The internal carotid artery has no branches in the neck. The external carotid artery has branches. So we have three carotids in the neck: external, internal, and common. So in these three, only the external carotid artery has the branches. The other two has no branches. So in some cases, you have to ligate the external carotid artery in some operations. So when you want to ligate the external carotid artery, you must always make sure that the vessel which you are going to ligate is having branches. So you must ligate only the vessel which has branches. That means you are ligating the external carotid artery. So from the external carotid artery, a branch comes. The first branch is the superior thyroid artery. The superior thyroid artery comes down and then it gives supply to the thyroid gland. Then there is one more vessel, that is the inferior thyroid artery. This inferior thyroid artery doesn't arise from the carotid artery. It arises from the subclavian artery. This is a subclavian artery. The subclavian artery gives off a branch that's called the thyrocervical trunk. The thyrocervical trunk gives off a branch that is called the inferior thyroid artery. This inferior thyroid artery arises from the thyrocervical trunk. It goes behind the internal jugular vein, vagus nerve, and common carotid artery. And it comes to the posterior border of the thyroid gland. And there it divides into multiple branches, and there it supplies to the thyroid gland. So arteries are two: superior thyroid artery, inferior thyroid artery. And there is one more branch which is seen only in about 3% of individuals. That is called thyroidea ima branch, which arises directly from the arch of the aorta. So this is the arterial supply. Then the venous drainage. One vein accompanies the superior thyroid artery, and that vein goes and joins the internal jugular vein. There is one more vein coming from the middle of the thyroid globe. That's called the middle thyroid vein. That also goes and joins the internal jugular vein. Then there is no vein accompanying the inferior thyroid artery. The vein is separately present and it arises at the lower pole of the thyroid gland, thyroid lobe. So this is the lobe, each lobe. So the lower inferior part of the thyroid lobe, you will find the inferior thyroid vein. This comes downwards and then joins the brachiocephalic vein. So you can see here the superior thyroid artery, the inferior thyroid artery. So these are the branches, arterial branches. Then the veins, there are three veins: superior thyroid, middle thyroid, and inferior thyroid veins. Lymphatic drainage of the thyroid gland. It has a subcapsular plexus and plexus is the parenchyma of the thyroid gland. So all these lymphatics, mostly they drain to the pretracheal and prelaryngeal lymph nodes. So these are the prelaryngeal lymph nodes situated in front of the cricoid cartilage, cricothyroid membrane, and thyroid cartilage. And there are lymph nodes situated in front of the trachea. They are called the pretracheal nodes. So the pretracheal and prelaryngeal lymph nodes, they drain most of the thyroid gland. They belong to the central compartment of the neck. And these lymph nodes also called as the nodes of Delphicus or Delphic nodes. Then from there, and some part of the lymph drains along the superior thyroid vein to the node situated along the superior thyroid artery. Then some drain to the node situated along the inferior thyroid artery. And there are some paratracheal nodes deep to the thyroid gland. So some of the lymph drains to the paratracheal nodes also. From there, the lymph drains to the upper deep cervical, the lower deep cervical, from there to the mediastinal nodes. There is rich lymphatic network in and around the gland. Subcapsular lymphatics drain mainly to the central compartment nodes, that is Delphian and paratracheal nodes, and to the nodes along superior and inferior thyroid veins. Nodes along superior and inferior thyroid veins, they drain to the deep cervical nodes and mediastinal nodes. I hope all of you know the levels of lymph nodes in the neck. The submandibular triangle lymph nodes, they are marked as level 1 lymph nodes. The lateral part of the neck, they are divided into, again, 3 parts, 3 zones. Level 2 means if you draw a line along the upper border of the thyroid cartilage. So the lymph nodes above the level of upper border of thyroid cartilage are called as the level 2 nodes. These nodes are mainly situated along the internal jugular vein. Then level 3 nodes, they are situated between a line drawn across the thyroid cartilage and cricoid cartilage, in between them. That is level 3. Then level 4 is below the level of cricoid cartilage. Level 5 is the posterior triangle lymph nodes. Level 6 is the anterior part of the neck, or that is also called as the central compartment nodes. Then level 7 is the superior mediastinal nodes. So all these lymph nodes except level 1 are affected or involved in thyroid lymph drainage. The microscopic appearance, each lobe is divided into multiple lobules. And each lobule, when you study it, you will find it is having follicles. And these follicles are lined by cuboidal cells. And in the center, you find globulin. This globulin is called the thyroglobulin. And in between the follicles, you find the parafollicular cells. The thyroid follicles, they secrete thyroxine and triiodothyronine. The parafollicular cells, they secrete a hormone. What is that hormone? What are the hormones secreted by parafollicular cells? Yes, that is called the calcitonin. So the gland contains many lobules which are made of follicles. The follicles are structural and functional units of thyroid gland. Each follicle is lined by flat or columnar epithelium depending upon the activity of the gland and is filled with thyroglobulin where hormones are stored. In between the follicles lie clusters of cells called parafollicular cells or C cells which secrete calcitonin. Relations of thyroid gland. Superficially, strap muscles and sternomastoid muscles. This is sternothyroid and thyrohyoid. Superficially, that one is the sternohyoid. Then medial surface of the thyroid gland is related to two tubes. They are the trachea and behind in the esophagus. Two muscles, the inferior constrictor of the pharynx and cricothyroideus muscle. There are two nerves. They are the recurrent laryngeal nerve that goes medial to the thyroid lobe, and there is one more nerve coming above, that is the external laryngeal nerve. On the posterior surface, you find the parathyroid glands. There is superior and inferior parathyroid glands. So here is the superior gland and here is the inferior gland. And there is carotid sheath. And more medially is the Berry's ligament. So this is the thyroid lobe. We are looking from behind, and this is the Berry's ligament. The Berry's ligament is nothing but condensation of the pretracheal fascia. So it gets condensed between the cricoid cartilage posterior surface and thyroid gland lobe on the posterior side. So there is a firm attachment of cricoid cartilage to the thyroid gland by Berry's ligament. And this ligament is very important ligament. Why? Number one, it is responsible for movement of the thyroid gland on swallowing. So already we have seen that pretracheal fascia is responsible for movement of the thyroid gland during swallowing. Second factor for movement of the thyroid gland and swallowing is mainly because of the Berry's ligament attachment. Berry's ligament. Then the Berry's ligament is also related to the recurrent laryngeal nerve. The recurrent laryngeal nerve, while it passes into the larynx, before it passes into the larynx, it is very closely related to the Berry's ligament. In thyroid operations, you must always expose and demonstrate the recurrent laryngeal nerve and keep it at a safe place while you are performing the lobectomy operation. Sometimes you will find it difficult to expose the recurrent laryngeal nerve. So in that case, what you do is, you see the Berry's ligament, and over the Berry's ligament, you will find definitely the recurrent laryngeal nerve. Berry's ligament is an important short notes question. It is the area of greatest adherence of the gland to the larynx. It is a condensation of pretracheal fascia. It is also responsible for the movement of thyroid during deglutition. This is the external laryngeal nerve. And here is the recurrent laryngeal nerve. So there are two nerves. They don't supply anything to the thyroid gland, but they are very important in the anatomy of thyroid gland because both of them are related to the thyroid gland. And when thyroid surgery is being performed, both these nerves are in danger. If these nerves are endangered or injured during surgery, the movements of the larynx will be affected. So the patient may get hoarseness of voice or sometimes the difficulty in breathing also because of the closure of the larynx. Hence, you must know about these two nerves. You can see here, this is the vagus nerve. Most of it is situated just behind the carotid artery and interjugular vein. Then, in the lower part of the neck, it crosses between the vein and the artery and lies anterior to the carotid artery. Then it descends down in front of the subclavian artery. While it's descending in front of the subclavian artery, it gives off a branch. This branch is the recurrent laryngeal nerve. This branch curls around subclavian artery and then goes into by the side of trachea. Then it passes in the tracheo-esophageal groove and ascends upwards. And it lies behind the thyroid gland. Then it crosses the Barrett's ligament and enters into the larynx between cricoid cartilage and thyroid cartilage. This is on the right side. On the left side, the vagus nerve comes down. It passes in front of the arch of the aorta. Here it gives off the recurrent laryngeal nerve. The nerve goes curving around the aorta and passes upwards again the same course as that of the right side. Why is it called recurrent? Because it takes a curved course again upwards. Sometimes, in some individuals, the nerve doesn't come like this. It comes directly from vagus and goes to the larynx directly. It comes from the vagus nerve in the upper part of the neck and crosses the vascular structures, goes behind the thyroid gland and enters the larynx. Then what do you call that nerve? If it doesn't come below the neck and then ascends upwards, if it comes straight from the vagus and goes directly laterally, medially to enter the larynx, then what do you call that particular nerve? Then it is not called the recurrent laryngeal nerve, but it is a laryngeal nerve. Yes, very good. That is called as the non-recurrent laryngeal nerve. During its course, it lies mostly in the tracheo-esophageal groove and is closely related to thyroid gland at three places. Number one, at the inferior pole of the thyroid gland. Number two, while it's crossing the thyroid, it crosses the inferior thyroid artery. It may pass anterior, posterior, or interdigitate with branches of the inferior thyroid artery. And number three is at the attachment of Barrett's ligament to the thyroid gland. So these are the three places where this nerve is related to the thyroid gland. This is important for us because during surgery of thyroid gland, this nerve is at danger at these three places. You must be careful at these three places. The right recurrent laryngeal nerve may be non-recurrent in 0.5 to 1% of individuals, where it courses obliquely from behind to reach the larynx and may not be related to the thyroid gland in such an occasion. The left non-recurrent nerve is rare but has been reported. So they now can go behind the inferior thyroid artery. This is the inferior thyroid artery. It may cross in front of the inferior thyroid artery. It may pass in between the branches of inferior thyroid artery, or it may pass anterior to the trachea and then comes into the tracheoesophageal groove. So these are the variations of recurrent laryngeal nerve. Then you must know one triangle in the neck that is called the Bayer's triangle. So you can see here, this is the triangle. This triangle is formed by the inferior thyroid artery, the recurrent laryngeal nerve, and the common carotid artery. So these three structures, they form the triangle, and this is called the Bayer's triangle. What is the importance of this Bayer's triangle? This is helpful to identify the nerve. To identify the nerve, you check for the common carotid artery, then see for the inferior thyroid artery, then in front of them you will find the recurrent laryngeal nerve. Then the nerve also can be identified if you can detect organ of Zuckerkandl. Zuckerkandl's tubercle is a pyramidal extension of thyroid gland, present at the most posterior side of each lobe. It occurs from the embryologic fusion of the ultimobronchial body with the median enlace and the lateral thyroid enlaces of the fourth pharyngeal pouch. Of course, I will tell you about this point when we talk about the development of thyroid gland. It is a constant landmark for recurrent laryngeal nerve and for superior parathyroid gland. You can see here, this is the thyroid gland. If you look at the posterior surface of the thyroid gland, you will find a pyramidal extension, not an extension, just projection outside. This pyramidal projection is called the Zuckerkandl tubercle. What is important of the Zuckerkandl tubercle? It points to the recurrent laryngeal nerve. So to identify the course of the recurrent laryngeal nerve, if you can see this Zuckerkandl tubercle, just immediately adjacent to that, you will find the recurrent laryngeal nerve in many of the cases. So this will help you to locate the recurrent laryngeal nerve. Then the external laryngeal nerve. External laryngeal nerve is a branch from superior laryngeal nerve. The superior laryngeal nerve is a branch from vagus. It descends medial to the internal carotid artery. At the level of the greater horn of the hyoid bone, the superior laryngeal nerve divides into external and internal laryngeal nerves. It descends to the superior pole of the thyroid gland and travels medially along the inferior constrictor muscle in the space of Reeves. So these anatomical details are very important because when you are doing thyroid surgery, you must safeguard these two nerves. It innervates the cricothyroid muscle, which is the tensor of the vocal cord. So this is the thyroid gland lobe. When you pull the superior pole laterally and downwards, and if you search between the thyroid gland and thyroid cartilage, you will find this external laryngeal nerve deep to the superior thyroid artery, and this is called the space of Reeves. The space of Reeves is nothing but the space between the medial surface of the upper pole of the thyroid gland and cricothyroids muscle. So here is the cricothyroids muscle. So the space between the cricothyroids muscle and the thyroid gland is called the space of Reeves. The space of Reeves contains the external laryngeal nerve. I hope you followed the anatomical points. Now, in clinical examination, to diagnose a case of thyroid swelling, certain points are necessary. So these points are based upon the anatomy. So what are these clinical points of interest? Let us see. It is enclosed in the pretracheal fascia, so it moves with swallowing. Pretracheal fascia arises from the fascia colli. So don't get confused between the fascia colli and fascia collis. What is fascia collis? What is fascia collis? Do you have any idea about it? Just one last week only we discussed about that fascia collis. It is actually not the penile fascia. Penile fascia is called the Buck's fascia. You are just near to that one. S collis fascia or fascia collis, both are same. Yes, what is collis fascia? Yes, it is the fascia in the perineum. The fascia collis, it is the inferior boundary of the superficial perineal pouch. It is subcutaneous fascia. Good. It continues in front into the scrotum, penis, and then continues onto the abdominal wall. It continues onto the abdominal wall as what fascia? It continues onto the abdominal wall as Karp's fascia. Yes. Okay. So because it is arranging from the pretracheal fascia and arises from the fascia colli and the deeper surface of the sternomastoid, thyroid gland is always situated deep to the sternomastoid, however large it may be. Pretracheal fascia extends into the superior mediastinum in front of the great vessels, and hence enlarged thyroid goiter can extend retrosternally. It is related to the recurrent laryngeal nerve on the medial side, so there may be hoarseness of voice because of the involvement of the recurrent laryngeal nerve in malignant thyroid. Related to trachea and esophagus, hence there may be dyspnea and dysphagia in malignant thyroid. It moves on swallowing. You can see here, this is the lobe of thyroid gland. So the patient is swallowing, the thyroid cartilage is moving, along with that one, the thyroid gland also is moving upwards. It is related to carotid vessels on the posterior border. That is why it produces a clinical sign called Berry's sign. Berry's sign positive means carotid vessels not felt in malignant thyroid. Do you know about Berry's sign? Or shall I explain now? What is Berry's sign? If you don't know, I will explain it. But this is also an important clinical sign. Thyroid clinical examination, you must be 100% thorough. And every point in thyroid is very, very important because number of questions will be there in thyroid in theory examination, and in clinicals every one of you will get one case of thyroid, either as a short notes, short case, or a long case. Okay, I will explain what is berry sign. A lobe of thyroid gland is swollen. A mass is there inside of the neck. What you must do is, you must feel at the posterior border of the mass. You must keep the neck relaxed. That means by bending the neck passively towards the side of examination. Keep your fingers at the posterior border of the mass and you try to feel. You must feel the carotid vessels. Why carotid vessels are felt there? When the thyroid gland enlarges in the pretracheal fascia, it pushes the carotid vessels behind it. So you will be able to feel the vessels. So if it is a benign enlargement of the thyroid gland, carotid vessels are felt at the posterior border of the swelling. If it is a malignant swelling, a carcinoma of the thyroid, for example, it doesn't displace, it always grows by infiltration. It won't push, it eats away the structures. So it eats away the carotid sheath and then engulfs the carotid sheath. That's why at the posterior border of the sternomastoid, at the posterior border of the mass, you don't feel the pulsations. That is called berry sign. I will explain here in this diagram. Here are the carotid vessels, and this is the thyroid gland. This is the pretracheal fascia. If the thyroid lobe enlarges, what it does is it simply pushes the carotid vessels behind it. So if you keep your fingers here at the posterior border of the swelling, you will be able to feel the pulsations if it is a benign swelling. If it is a malignant swelling, it will infiltrate the carotid sheath, both anteriorly, posteriorly, and laterally. That is why you will not be able to feel the carotid pulsations at the posterior border of the swelling. So if you feel at the posterior border of the swelling, you can't feel the carotid vessels. So this is called the berry sign. You have to stand behind the patient, tilt the head to the side of examination, and keep your fingers at the posterior border of the swelling and feel for the pulsations. If it is a malignancy of the thyroid, you cannot feel the pulsations. Then anatomical points of surgical interest. During surgery, certain points you must bear in mind regarding anatomy. This is related to the recurrent laryngeal nerve. So it may get injured while ligating the inferior thyroid artery. Not only while ligating the inferior thyroid artery, we have seen it is near to the thyroid gland at 3 places. So whenever you are doing surgery at these 3 places, the recurrent laryngeal nerve may be in danger. Tell me those 3 places where recurrent laryngeal nerve is closely related to the thyroid gland. Already I told you, it is related to the thyroid gland at 3 places. And at these 3 places, it is in danger. What are these 3 places? Very good. It is Barrett's ligament, inferior pole of the thyroid gland, and inferior thyroid artery. Very good. Please remember, these 3 are important. Related to the external laryngeal nerve. So it may get injured while ligating the superior thyroid artery. Presence of parathyroid glands on the posterior border So there may be parathyroid insufficiency in total thyroidectomy. Actually, the parathyroid glands are embedded in the capsule of thyroid gland. So when you remove the whole thyroid gland, both lobes, then all the four parathyroid glands also get removed, and that may produce parathyroid insufficiency. That's why you must always take special precaution to dissect these parathyroid glands away from the lobe and keep it aside. So this is about the anatomy of thyroid gland. Any doubts? We will go to the physiology of thyroid gland. Okay, physiology of thyroid gland. The iodide circulating in the blood, the iodide comes into the blood through the gut, through the swallowed water. So iodide actually comes to the human body through drinking water and through some foodstuffs. And most common source is only from the drinking water. From the gut, it gets absorbed into the bloodstream. Then it is circulating in the blood. This iodide is being taken up by two structures mainly in the body. They are the thyroid gland and the kidney. 30 to 40% circulating iodide is taken up by the thyroid gland, and the remaining is taken up by the kidneys. How much iodide has to be taken by the thyroid gland is dictated by thyroid stimulating hormone, that is called TSH, which is secreted by TSH is secreted by what? Others also can respond. This is a very common, easy question. Why others are not responding, I do not know. Please participate in the discussion. Then I will get the confidence that you are following. If you are not participating in the discussion, I will get a doubt whether you are hearing or sleeping. Nothing you will lose by expressing your answer, whether it's right or wrong. You always gain. Okay, it is the anterior pituitary which secretes TSH. So under the influence of TSH, the iodide is absorbed into the acinar cells. Here, iodide under the influence of peroxidase enzyme gets converted to iodine. The tyrosine present in the cytoplasm of the thyroid follicular cell combines with iodine to form monoiodotyrosine and diiodotyrosine. One molecule of MIT plus one molecule of DIT becomes T3, and two molecules of DIT becomes T4. From the acinar cell, now the T3 and T4, they percolate into the thyroglobulin, the base of the globulin. and they are bound to the globulin present in the follicle. When thyroid hormones are required, that means the globulins store this T3 and T4. When thyroid hormone is required by the body, then TSH activates an enzyme, the proteolytic enzyme. This proteolytic enzyme breaks the globulin and releases the T4 and T3 and releases the MIT and DIT. T3 and T4, they are released into the bloodstream, and there part of them are bound to the protein, and they are circulated in the bloodstream as protein-bound thyroid. The free hormones are metabolically active hormones. The MIT and DIT, they are acted upon by an enzyme called deiodinase. This deiodinase splits the MIT and DIT into iodides and tyrosine. The iodide goes into the iodine pool. That means it goes into the bloodstream and again gets absorbed by the thyroid gland. So here most of the steps are under the control of thyroid stimulating hormone. So there are two enzymes in the synthesis of thyroid hormones. One is the peroxidase enzyme. The other is the deiodinase enzymes. If peroxidase enzyme is absent, there will be deficient synthesis of T4 and T3. If there is absence of deiodinase, so when deiodinase is absent, what will happen? The MIT and DIT that is there stored in the thyroglobulin are not being broken down. So the MIT and DIT levels, they go on accumulate in the thyroglobulin. So they accumulate and then they regurgitate into the circulation. So the MIT and DIT as such, they come into the bloodstream and they are excreted by the kidneys. So because of this, there will be diminution of the iodine pool, and that can lead to iodine deficiency goiter. Pituitary thyroid axis. This is the pituitary, this is the anterior pituitary, which secretes the TSH under the influence of thyrotropin releasing hormone. It secretes TSH. TSH is also called as the thyrotropin. So under the influence of TSH, thyroid produces T4 and T3. This T4 and T3, they can reflexly reduce, influence, or block anterior pituitary to secrete TSH. That means if T4 and T3 are in excess, they inhibit secretion of TSH from anterior pituitary. The functions of thyroid hormones, they maintain body metabolism, that is caloric, protein, fat, and neurological metabolisms. Their secretion is under control of thyroid stimulating hormone secreted by anterior pituitary. The calcitonin is also called as the thyrocalcitonin. It is the other hormone secreted by thyroid by C cells. It lowers serum calcium by inhibiting calcium mobilization from the bones. That means it antagonizes the action of parathormone. Parathormone moves calcium from the bones to raise the blood calcium level. But calcitonin does the opposite. It moves the calcium from the blood into the bones. It is secreted in excess in medullary carcinoma of thyroid and acts as a tumor marker. The excess calcitonin does not manifest as hypocalcemia in medullary carcinoma. So this is about the anatomy and physiology of thyroid gland. Now let's discuss about the investigations of the thyroid disease. I hope you have followed the anatomy and physiology because this is very important to understand the investigations. Essential investigations in any case of thyroid gland disease. Thyroid function tests. There are 3 tests, that is the serum, thyroid stimulating hormone, T3 and T4. Thyroid autoantibodies, FNAC, that means fine needle aspiration cytology of all palpable discrete swellings. Optional investigations being I-131 scan for discrete swellings with toxicity, chest X-ray if tracheal deviation or intrathoracic goiter extension is present, CT or MRI scan if thyroid is fixed, that means if it is malignant, ultrasound scan. Thyroid function tests. Okay, Manugya has raised one doubt. Why calcium levels doesn't fall when there is medullary carcinoma? The amount of calcitonin secreted by medullary carcinoma is so little that the calcium levels are not being influenced. That's why you don't find much difference in the calcium levels. For the calcium levels to alter, there should be still more larger quantities of calcitonin that should be available in the blood. So that much of calcitonin is not secreted by the medullary carcinoma. That is why you don't find changes in the calcium. Thyroid function tests. It is to evaluate the level of thyroid function. The tests being basal metabolic rate and PBI. These are only of historical interest and are not used nowadays. Serum thyroid hormones. So you can measure T4, T3, TSH, and TRH. The incipient or developing thyroid failure is characterized by rise in the TSH levels with normal T4 and T3. Sometimes the T4 and T3 are normal, but TSH only is altered. So if such is there, then we call it as it is incipient thyroid problem. If TSH is more, we'll say it is incipient hypothyroidism. If TSH is less, we call it as incipient thyrotoxicosis. The thyroid hormones are transported in the blood, mainly bound to a serum protein called thyroid binding globulin. A small fraction of the hormones are transported free in the blood, 0.03% of T4 and 0.3% of T3. The levels of total thyroid hormones is dependent upon the level of serum proteins. So because much of the thyroid hormones are being transported bound to the serum proteins. So by any chance, if serum proteins are less, then thyroid hormones also will be shown as less, but they are produced normally. But the serum proteins are less, so automatically these thyroid hormones are also shown as less. So elevate levels of serum proteins as in pregnancy, contraceptive pill usage give false high readings. Similarly, decreased levels of serum protein as in liver disease, nutritional deficiency or congenital low serum thyroid binding globulin gives false low levels. Hence, estimation of free thyroid hormones in the blood gives accurate information, especially in case of suspected serum protein abnormalities. So, for example, a pregnant woman comes. If you want to check for the thyroid, you must always go for only free thyroid hormone estimation, not the total thyroid hormone levels. Because the serum proteins are usually increased, so you usually get a false high result. So when you look at those false high results, you will interpret it as thyrotoxicosis. Hence, to prevent that problem, you must always check for the free thyroid hormones. The thyroid function tests, T4, T3 are low. So when they are low, automatically TSH will be elevated. It is primary hypothyroidism. T4, T3 low, and TSH also is low. This is called secondary hypothyroidism. That means the T3 and T4 are low here because TSH is not being secreted. So there is some anterior pituitary problem. So this anterior pituitary problem is causing hypothyroidism. So this is secondary to pituitary problem. So we call this as secondary hypothyroidism. T4, T3 are normal, but only TSH is elevated. So already I told you this is called incipient hypothyroidism, also called as subclinical hypothyroidism. T4 and T3 are elevated. TSH is low. It is hyperthyroidism. T4 is normal, T3 only is elevated, TSH is undetectable. We call this as T3 hyperthyroidism. T3 and T4 are normal. TSH is low or undetectable. Then again, we call this as subclinical hyperthyroidism or incipient hyperthyroidism. So that is about the thyroid function test. The other tests of thyroid disease being thyroid autoantibodies estimation. There are two antibodies, thyroid antithyroid peroxidase antibody and antithyroglobulin antibody. These are elevated in Hashimoto's thyroiditis and sometimes in thyrotoxicosis also. Imaging studies for thyroid gland. Ultrasound scanning. It helps to scan the gland and the regional lymph nodes draining the thyroid gland. You study mainly for the vascularity and microcalcification. So whenever there is microcalcification with increased vascularity, so that is a sign of malignancy. Scanning also helps to guide the aspiration cytology. So where the nodule is there, you can make out and you can aspirate directly from the nodule. CT and MRI scan indications suspicion of retrosternal goiter and in malignancy to evaluate airway invasion and prevertebral fascia invasion. PET scan, limited use in thyroid malignancy, useful in recurrent thyroid cancer. FNAC, it is the investigation of choice in all discrete nodular goiters or solitary nodular goiters. Basing upon the FNAC reports, they are classified as THY1 is non-diagnostic. That means you are not able to make any diagnosis out of it. THY2 is non-neoplastic. THY3 means follicular lesion. THY4 means suspicion of malignancy. THY5 means malignant. Then radioisotope scan, that is the I-131 scanning. It is useful to determine hyperfunctioning thyroid in toxic nodule and nodular toxic goiter. I hope you understand the meaning of the isotope scanning. What is an isotope? What is the isotope? Any element, if its atomic number is altered, it is called an isotope. So the atomic number is altered. So for example, I-131. What is the normal atomic number of iodine? What is the normal atomic number of iodine? No, it is not 51. It is not 51. I think it is 128. So if the atomic number is altered, how can you alter the atomic number? By taking away some of the electrons or by adding electrons. So when you add electrons or delete some electrons, its chemical nature is not altered, but it exhibits emission of gamma rays, because that particular atom becomes unstable once its electrons are added or deleted. Normally the protons and electrons, they should be equal in number. If there is an inequality, the balance is lost. So the stability of the atom is lost. So the atom starts disintegrating. So when it's disintegrating, it emits the gamma rays. So that is nothing but radiation. When you give iodine to a person, I have already told you that iodine is absorbed by two structures. One is the kidney, the other is the thyroid gland. So when you give a iodine isotope, that means I-131, which is emitting the gamma rays or X-rays, it is absorbed by the thyroid gland. So you can measure by looking at the radiation. So if you can keep a counter here which can measure radioactive emissions, then you can say how much of radiation is being emitted by thyroid gland. So how much of radiation is emitted? That depends upon how much of iodine is being taken up by the thyroid gland. Similarly, if you take an X-ray film and keep it above the front of the neck, give radioactive iodine to the patient, that is I-131. That goes into the blood and it is trapped by the thyroid gland. So once it gets trapped by the thyroid gland, if it is uniformly taking up the I-131, it gives a uniform butterfly-shaped shadow. If one particular area is taking more of I-131, that means it's taking more of iodine. That means it is a hyperfunctional nodule. If some area is not at all taking the iodine, that means it is a hypofunctional nodule. So you can evaluate the functional ability of the thyroid nodules. So that is the use of doing I-131 scanning. So it is used to determine hyperfunctioning thyroid in toxic nodule and nodular toxic goiter. It is also useful to detect bony secondaries after thyroidectomy in follicular carcinoma thyroid. So these are the investigations of thyroid gland. Next is the development of thyroid gland. So this is the tongue. In the midline of the tongue, at the junction of anterior 2/3 with the posterior 1/3, there is a small depression. What do you call the depression in the tongue? In the midline, at the junction of anterior 2/3 with the posterior 1/3, there is small depression. What do you call that? Okay, that's called the foramen cecum. That's called the foramen cecum. So, for the foramen cecum in the fetus, an inward growth of epithelial cells will occur as a tract. This tract is called as the thyroglossal tract. This tract passes through the substance of the tongue. Then it passes in between the two mylohyoid muscles. It comes to the hyoid bone. At the hyoid bone, it is very much closely related to the hyoid bone. Either it is adherent to the hyoid bone or passes through the hyoid bone. In this point, you must remember, it passes through the hyoid bone or closely adherent to the hyoid bone. Then it passes in front of the thyrohyoid cartilage, so thyrohyoid membrane, then in front of the thyroid cartilage, then in front of the cricoid cartilage, then in front of the first and second and third tracheal rings. There it develops into the thyroid gland. From the fourth pharyngeal pouch, a projection occurs, and that is called the ultimobronchial body. This ultimobronchial body then comes and amalgamates with this thyroid gland. And this ultimobronchial body actually gets parafollicular cells from neural crust. So the neural crust differentiates into many types of cells. Many of the endocrinal glands are developed from the neural crust or neural crust derivatives. The parafollicular C cells also are derived from the neural crust. These neural crust cells, they come into the fourth pharyngeal pouch, and in the form of ultimobronchial body, it comes and merges with the thyroid gland. So the parafollicular cells are derived from ultimobronchial body. So at the place where it gets fused, that forms the posterior border of the thyroid gland. And at this place, you will find the pyramidal projection. That's called the tubercle of the Zuckerkandal. Thyroid developed from the thyroglossal tract, developed from the foramen cecum of the tongue. It migrates caudally and passes in close continuity or sometimes within the hyoid bone. It descends to the front of the trachea and amalgamates with the ultimobronchial body developed from the fourth pharyngeal pouch. The parafollicular cells from neural crust reach thyroid through ultimobronchial body. So just here to remind you about the neural crust derivatives: adrenal medulla, neurosecretory cells of the heart and lungs, carotid body, parafollicular cells of the thyroid, melanocyte, parasympathetic ganglia, spinal ganglia and ganglia of 5th, 7th and 10th nerves, stroma of salivary glands and endocrine glands, dermis, cranial vault, satellite cells of sensory ganglia, squamous cells of PNS, peripheral nervous system. Why I am mentioning all these things here? What is the necessity here to know about these things here? You may be thinking like that. The need is, I want to emphasize here that in certain tumors, you will find neoplasms of the neural crust derivatives. There may be neoplasm of the adrenal medulla. parasympathetic ganglia, neurofibromatosis. Then medullary carcinoma of the thyroid gland. Medullary carcinoma of the thyroid gland arises from the parafollicular cells of the thyroid gland. So in a patient, all these things may be there. You will call it as multiple endocrine neoplasia syndrome, MAN syndrome. So the derivatives of this neural crest is responsible for production of this MAN syndrome. So to emphasize that point, I am telling about the neural crest derivatives. So if you know these neural crest derivatives, then you can easily understand why so many neoplasms are there in a single patient. Because it is an abnormality of the mother neural crest cell which causes the tumors in the derivatives. Now we will study something about the developmental abnormalities. Thyroid tract, some abnormalities may be there with thyroid tract. We have seen the course of the tract coming from the foramen cecum through the tongue into the hyoid bone, from there in front of the thyroid cartilage, in front of the cricoid cartilage, then in front of the trachea. So in its course, the thyroid tract, what it will do, once it develops into the thyroid gland, it gets obliterated and disappears, just like process vaginalis. Sometimes in this tract, it develops additional thyroid gland. Or it may develop thyroid gland not at the trachea, but at some other place. So there may be residual thyroid along the course producing ectopic thyroid gland. Sometimes there may be failure of resolution of the tract. This leads to thyroglossal cyst formation. So congenital abnormalities of thyroid gland are of two types. Number one, ectopic thyroid. Number two, the thyroglossal cyst. So this is the thyroglossal tract. The thyroglossal tract may not disappear. So then it will contain degeneration of the cells. It produces a cyst. This is called thyroglossal cyst. The cyst can develop in front of the hyoid bone, above the hyoid bone, the floor of the mouth, in front of the thyroid cartilage. It can form ectopic thyroid at the foramen cecum, over the isthmus of the thyroid gland, and in the midline in front of the neck. Sometimes it may pass downwards into the mediastinum and can develop into thyroid gland in the mediastinum. If it develops at the foramen cecum, it is called as the lingual thyroid. If it develops over the isthmus of the thyroid gland, it is called as the pyramidal lobe. Ectopic thyroid is due to the development of thyroid gland from the thyroglossal duct anywhere in its course. It may occur in the following positions: lingual, cervical, and intrathoracic. It is prone for carcinoma than the normally situated thyroid gland. You can see here the lingual thyroid. So this is the tongue at the foramen cecum. You can see a mass situated over the tongue. So this is the thyroid gland. It forms as a round swelling at the foramen cecum of the tongue. It may be the sole thyroid tissue. Symptoms: this mass may be coming in the way of swallowing. So this produces dysphagia, impairment of speech. Stridor. What is stridor? What is stridor? Okay. What is wheeze? Wheeze. Stridor and wheeze are both different. They are not the same. Whenever a patient gets difficulty in breathing during inspiration, it is called stridor. Difficulty in breathing during expiration is called wheeze. So both of them are produced due to narrowing of the air passages. If the major airway tract passage is partially occluded, major airway means trachea or the bronchi. If they are partially occluded, there will be difficulty during inspiration, and that produces a noise. That is the stridor noise. Then, whenever there is block in the bronchioles or smaller bronchial passages, there will be a noisy breathing. That's called the wheeze. So stridor means there is inspiratory obstruction. Sometimes there may be hemorrhage. Differential diagnosis, you must differentiate it from lingual tonsil. Lingual tonsil is not situated exactly in the midline. So the posterior one-third of the tongue, the whole posterior one-third of the tongue may become hyperplastic. Carcinoma posterior one-third of the tongue. Investigations: ultrasound scan of the neck to demonstrate the presence of thyroid in the normal position. Many a times, the normal thyroid is absent. Radioactive iodine uptake test to confirm lingual thyroid and to demonstrate the presence of thyroid in the normal position. Treatment: suppressive dose of L-thyroxine. So if you give suppressive dose means the normal daily requirement. That means about 100 to 125 micrograms per day. That varies from age of the patient, and that also depends upon build of the patient. So you give an approximate dose of 100 micrograms or 125 micrograms. If it is a child, you give a lesser dose. That means the total body's requirement should be supplemented by external medication form in form of thyroxine tablets. So when you are giving thyroxine from external source, so what is happening? This thyroxine will block the TSH levels. So when TSH is blocked, automatically the thyroid gland becomes atrophic. It gradually atrophies. So even for a normal person, if you give thyroid hormones, the thyroid gland becomes atrophic. Rarely, radiation therapy or surgery is indicated. The second abnormality of the congenital abnormality is the cervical thyroid, also called the median ectopic thyroid. It forms a swelling in the upper part of the neck. It may be the sole functioning thyroid gland. It may be mistaken for thyroglossal cyst. It is differentiated from thyroglossal cyst by ultrasound scan of the neck and by FNAC of the swelling. Pyramidal lobe, the lower part of the thyroglossal tract after developing into thyroid gland, develops into the thyroid tissue at the upper part of the isthmus on one side of the midline, usually on the left side. So ectopic thyroid means it can be number 1, lingual thyroid, number 2, median cervical thyroid, number 3, pyramidal lobe. So these 3 are called the ectopic thyroid. Sometimes some other swellings are also called as ectopic thyroid, but there are misnomers. They do not represent developmental anomaly. That is something different. So when you supplement thyroxine for suppressing lingual thyroid, you must give the daily requirement. Whatever the daily requirement is there for the patient, that daily requirement has to be supplemented. For example, a child is there. A child of about 5 years comes to you with a lingual thyroid. Then approximately the child requires about 25 micrograms of thyroxine. You give 25 micrograms of thyroxine. Then is the daily requirement sufficient or not? How do you estimate? You have to do the blood examination. Serum thyroxine has to be evaluated after 15 days. If serum thyroxine and triiodothyronine are within normal limits and TSH is within normal limits, then you say 25 micrograms is sufficient for the patient's daily requirement. If T3 and T4 are low or TSH is high, that means that the daily requirement is not adequate. Because the lingual thyroid is there, it may be also secreting. So you must give that amount of thyroxine which suppresses the lingual thyroid. That means the thyroid levels must be normal, TSH must be normal, and the lingual thyroid must reduce in size. That means you are giving adequate quantities of the thyroxine. That means you meet the daily requirements also there. It is not only to suppress the TSH, but also to supplement the daily requirement. The lingual thyroid patient may be hypothyroid or may not be hypothyroid. They may be euthyroid. For a euthyroid patient, if you supplement thyroxine, what is happening? There will be more of thyroxine in the blood. So that means normal secretion is there, plus you are adding. So this will cause reduction of TSH. So this reduction of TSH will cause suppression of the lingual thyroid. So you give for 15 days, estimate the thyroid hormones and look at the lingual thyroid. The swelling is decreasing, the thyroid levels are normal, you continue the same dose, within 3 months, the lingual thyroid will disappear. You will not see the lingual thyroid. Misnomers of ectopic thyroid. There is one word called as lateral aberrant thyroid. This is also frequently given in your theory examination. Stroma ovary. Now you can see here, this woman came to me with this nodule inside of the neck. lateral side of the neck. This nodule is not moving and swallowing. Not moving and swallowing means this is not a nodule in the thyroid gland. I have done FNAC from this nodule. The FNAC report came as thyroid gland. It is not moving and swallowing, situated on the lateral side of the neck, but FNAC is showing thyroid gland structure. Such is called as lateral aberrant thyroid. Then what is lateral aberrant thyroid? It is not moving, it's swallowing, means it is not thyroid gland. But why thyroid is there then? Lateral aberrant thyroid is not a congenital anomaly. It is not from ultimobronchial body. Earlier people thought that such thyroids in the lateral part of the neck, which are not part of thyroid gland but showing the thyroid structure, were thought to be derived from ultimobronchial body remnants. But ultimobronchial body supplies only parafollicular, not thyroid tissue. But earlier anatomists, they thought that that is due to ultimobronchial body remnant. But what is it? If it is not ultimobronchial body remnant, what is it? It is a mass of neoplasm found in the lymph nodes on the lateral side of the neck from papillary carcinoma of thyroid. Sometimes there will be cancer in the thyroid gland. The cancer will be only microscopic focus. That means it is not palpable. But even though it is microscopic, it metastasizes to the lymph nodes of the neck. When it metastasizes to the lymph nodes of the neck, it produces a follicular architecture in the lymph node. So if you remove the lymph node and study it, it looks just like a thyroid gland. The lymph node will have the structure of a thyroid gland. So this is a mass of thyroid metastasis in a lymph node. So lateral aberrant thyroid is a misnomer which earlier was thought that it was a remnant of ultimobronchial body. But now it is shown that it is nothing but a metastatic deposit from occult primary carcinoma in the thyroid gland depositing in the lymph nodes of the neck, giving the structure of thyroid gland. So this is called lateral aberrant thyroid. Then stroma of ovary. It is also not an ectopic thyroid. Stroma of ovary. What is the meaning? What is stroma? What is the meaning of stroma? Stroma is the name of a river. The river flows in Bulgaria. On the banks of this river, because this river arises from the Alps mountains, they are all ice mountains. So when ice is melted, the water will be there in the river. So this river is flowing only through the ice. It is a pure ice water, ice-derived water. So it has not passed over the ground. If it passes over the ground, then it dissolves the minerals that are there in the ground. Because it is not exposed to the ground, it doesn't have iodine. This water is free from iodine. So people who live on the banks of this particular river, they have iodine deficiency goiters. That is why this thyroid was nicknamed as stroma in their country. So stroma means it is the name of the river, but it is likened to the thyroid gland. Then what is stroma of ovary? Presence of thyroid in ovary is called a stroma of ovary. We have seen thyroid gland in the floor of the mouth or the tongue. We have seen the thyroid gland as pyramidal lobe, as median ectopic gland. Then even in the ovary also sometimes you will find the thyroid gland. Then it is called stroma of ovary. It is not an ectopic thyroid gland. Then what is it? It is a part of ovarian teratoma. We have seen teratoma. Teratoma means, what is teratoma? What is teratoma? Yes, it is a tumor from totipotent cells, which can give rise to various forms of embryonal tissue. It can give epidermal tissue. The tumor can have the mesenchymal tissues. The tumor can have endodermal tissue. So, a ovarian teratoma may have the ovary. That is because it is part of a teratoma. This may rarely cause thyroidoscosis. So this is about ectopic thyroid. Then thyroglossal cyst site, it can occur any part of the thyroglossal tract in order of frequency. It may be subhyoid, over the thyroid cartilage, and in suprahyoid areas. It occurs in the midline except over the thyroid cartilage. So you can see here one thyroglossal cyst above the hyoid bone. So this is suprahyoid thyroglossal cyst. This is one more. This is thyroglossal cyst situated over the thyroid cartilage. Over the thyroid cartilage, it is not on the midline. It is slightly to the one side, so most common to the left side. It is over the cricoid cartilage. It can manifest at any age. It can be there in infants, children, or old age people. Swelling lies in front of the neck in the midline. Cyst on the thyroid cartilage is situated slightly to the one side. It may be solid or cystic. It moves on swallowing and on protrusion of the tongue because of its attachment to the tongue by the thyroglossal tract. The thyroglossal tract has not disappeared. That is why the swelling occurs in the thyroglossal tract. So if the patient protrudes his tongue out, the thyroglossal tract is pulled upwards, so the swelling also moves upwards. So you can see here the swelling. When you make the patient to protrude the tongue out, the swelling is being pulled upwards. So this is how you must do the test. First, you must ask the patient to keep the mouth open. Then ask her to protrude the tongue out and to retract the tongue. So whenever the tongue is protruded out, the swelling moves up. Whenever it is retracted in, the swelling moves down. Again, this child, you can see, this is the swelling here. When tongue is protruded, the swelling is moving upwards. When you can't appreciate by inspection, then what you do is you just catch hold of the swelling. Then ask the patient to protrude the tongue. Then you will feel the tug or the pull of the swelling upwards. Of course, in children, sometimes it will be difficult to make them protrude the tongue. So you keep your finger in between the jaws, so they keep their mouth open. Then you can ask them to protrude the tongue out. Investigations: ultrasound scan of the neck to know whether it's cystic or solid swelling. An ultrasound scan of the neck also is helpful to know whether thyroid gland is there in the normal position or not. Isotope scan with I-131 scanning, then FNAC. The complications of the thyroglossus cyst: number one, infection. The infection can lead to abscess formation. Abscess is incise or bus, then it leads to a fistula. Whenever fistula is there, that produces recurrent infection. Thyroglossus fistula is never congenital. It is always acquired. First, it starts as a thyroglossus cyst. It becomes later abscess. The abscess bursts open and forms the fistula. Sometimes the cyst may develop into papillary carcinoma of thyroid gland. Thyroglossus cyst is the commonest midline swelling of the neck during infancy. So differential diagnosis is the thyroglossus cyst moves with swallowing and moves on protrusion of the tongue. So differential diagnosis: swellings which do not move on swallowing and on protrusion of the tongue. So there may be some swellings in the midline of the neck which do not move on swallowing and on protrusion of the tongue. They are epidermoid cyst and dermoid cyst. So how do you differentiate? Because of lack of movement during protrusion of the tongue and during swallowing. Then swellings which move on swallowing but not on tongue protrusion. Pretracheal pleurolaryngeal lymph nodes which are situated in the midline, subhyoid bursa, pyramidal lobe enlargement, cyst of the isthmus of the thyroid gland. Then swellings which move on swallowing and protrude the tongue, ectopic thyroid. So these are the things you have to differentiate from thyroglossal cyst. Treatment: surgical treatment only is the option. Indications: size more than 1 centimeter is prone for infection. That is why any cyst which is more than 1 centimeter has to be removed. The operation is called the cyst trunks operation. So this is the thyroglossal tract. I already told you the thyroglossal tract passes through the hyoid bone. Thyroglossal cyst is nothing but the remnant of thyroglossal tract. The cyst forms in the remnant of the thyroglossal tract, which has not been obliterated. The tract is still present. So in one part of the tract, there is a cystic dilatation. If you remove only the cyst, the remaining tract is left behind, and that may develop cyst at a later date. So what is your treatment? Tell me. So what you should do? A patient with thyroglossal cyst comes to you. I told you, if you just remove the cyst, because the tract is still remaining, the patient may develop recurrence of cyst in any other part of the tract. So what is your treatment? Very good. So your treatment should be removal of the cyst along with the whole tract. Okay, along with the whole tract, that is all right. But here we have seen that the tract is passing through the body of the hyoid bone. So what the treatment? You have to remove the cyst along with the tract and along with the body of the hyoid bone, because you cannot separate the tract within the body of the hyoid bone. It gets amalgamated there. So you will not be able to remove the tract separately from hyoid bone. That is why what you do is you remove the body of the hyoid bone also. This is called cyst operation. So thyroid tract is intimately related to the hyoid bone. Sometimes passes through it and sometimes curves below the lower part of the hyoid bone and descends down. Hence the whole tract, including the body of the hyoid bone, up to the base of the tongue, along with the cyst, has to be excised. So that is about the thyroglossal cyst. Then thyroglossal fistula. It is not a congenital disease. Already I told you, fistula is not due to congenital problem. It is due to acquired infection of the thyroglossal cyst, forming an abscess, and the abscess is bursting. It is always acquired due to infection of the thyroglossal cyst. Clinical features: sinus tract is in the midline and adherent to the hyoid bone or trachea. It discharges mucoid or mucopurulent fluid. You can see the movement of the fistulous tract on protrusion tongue. The sinus moves on protrusion tongue. You can see it. Sometimes the sinus will be such a small size. So if the fellow is asked to protrude the tongue, you can see the sinus is moving upwards. I'll show a small video clip where the thyroglossal fistula is moving upwards on protrusion of the tongue. This is the fistulous opening. This black dot. He's getting mucoid fluid from that. So whenever the fellow is swallowing, you can see that it's moving. You can see that mucoid fluid is coming from that. So when he protrudes the tongue, it is being pulled upwards. So I hope you can appreciate this. Differential diagnosis: you must differentiate from infected sebaceous cyst, tuberculous sinus. Treatment is same as that of the thyroglossal cyst. Okay, this is about thyroid anatomy, physiology, development, and congenital anomalies. I will stop thyroid discussion here and we'll go to the previous day's topic. We are left with some remnants in the disease of the urethra and penis. So I will finish that particular part. Is it okay? So it is not the penis and scrotum, it is this testis what we have to study. Okay, we have studied up to this point in the previous class. That is, whenever a testicular tumor is there, the treatment is, what is the treatment for testicular tumor? What is surgical treatment for testicular tumor? You are only correct by 50%. You are given only part of the answer. What is the total answer? Yes, very good. It is the high level architectomy. Inguinal canal open, cord ligated the internal ring and cut. Then the testis along with the tunica vaginalis and 3 spermatic fascia is dissected from the squatter structures, delivered into the inguinal canal, and testis along with the cord is removed. After the removal of the testis, then you send it for histopathological examination. Histopathological examination will tell whether it is seminoma or teratoma. If it is seminoma, you do CT scan of the chest, abdomen, and pelvis with the tumor marker study to reveal for any metastasis. And if they are not detected, it is considered as stage 1 disease. So if disease is confined only to the testis, the other sides like the lungs and the bones do not have the tumors, then that means that it is only stage 1 disease. Earlier, adjuvant radiotherapy was given to the para-aortic nodes, but it was found that only 15 to 20% of the stage 1 patients have subclinical metastatic disease. And so the current protocols recommend surveillance by tumor marker study. What is the tumor marker study you do for testicular tumor? What is the tumor marker study you do for testicular tumors? Or otherwise, what are the tumor markers for testicular tumors? Very good. The alpha fetoprotein and HCG and lactic dehydrogenase. Very good. So these are the tumor markers. So you have to do the tumor marker study that will tell you whether the tumor is recurring or not. So if it is stage 1 disease, that means the disease is confined only to the testis without any metastasis. The current protocols suggest that patient needs only surveillance. Surveillance means you watch the patient by regular tumor marker study once in every 3 months and CT scan of the chest, abdomen, and pelvis. And if they detect metastasis, then adjuvant chemotherapy is given with platinum-based drugs like carboplatin. Acute toxicity such as lethargy and days missed from work was less with carboplatin than with radiation therapy. For stage 2 to stage 4 disease, combination chemotherapy with bleomycin, etoposide, and cisplatin are given. Treatment of non-seminomatous germinal cell tumors. So after architectomy, if the report comes as non-seminomatous germinal tumor, its course is more aggressive than seminoma. So when the elements of both seminoma and non-seminoma are present, or the alpha fetoprotein concentration is elevated, the tumor should be treated as non-seminoma. For stage 1 disease, low-grade tumors are managed by tumor surveillance, and high-grade tumors are managed by adjuvant BEP chemotherapy because these tumors are more aggressive. So though it is stage 1, you give chemotherapy, adjuvant chemotherapy. Stage 2 to stage 4, you give combination BEP chemotherapy. If retroperitoneal metastasis does not disappear after chemotherapy, you do retroperitoneal dissection is performed. That means in stage 2 and stage 2 to 4, there will be retroperitoneal lymph nodal metastasis in teratoma. So what you do is you give chemotherapy and check. If the metastasis disappears, it's okay. Otherwise, you have to do retroperitoneal dissection of all those enlarged lymph nodes. So by transperitoneal open method or by laparoscopy, all nodes along with testicular vein and adjacent fibrofatty tissue to include lymphatics from the internal ring to insertion of testicular veins is performed. Complication is retrograde ejaculation by damaging the hypogastric plexus. Follow-up, this is done every 3 to 4 months for the first 3 years, every 6 months for 4 to 7 years, then annually up to 10 years. So you have to follow up by CT scan of the chest, abdomen and pelvis, tumor marker study with AFB and HCG. Prognosis is dependent upon the histological type of the tumor. 5-year survival rate for seminoma, it is stage 1 around 95%, stage 2 75%, teratoma, it is stage 1 and 2 85%, stage 3 and 4 60%. Testicular tumors of the childhood, malignant anaplastic teratomas, they occur before 3 years. Interstitial tumors, most of them benign, so organ sparing surgery is done for all small tumors. For larger tumors, you have to do architectomy. Epidermal tumors incidence is extremely rare. Types: benign mesothelioma, malignant sarcoma, secondary carcinoma. Presentation: solid mass in the epidermis. Treatment depends upon the nature of the lesion. Disease of the scrotum. The commonest disease of scrotum is the sebaceous cyst. You can see these are the multiple sebaceous cysts in the scrotum. So they can produce such gross deformity of the scrotum also. Idiopathic scrotal gangrene, also called Fournier's gangrene. This is a frequently asked question in the theory examination. Etiology: idiopathic, probably infective with vascular cause. There are hemolytic streptococci, E. coli, Staphylococcus aureus, Clostridium welshi. So for unknown reasons, the scrotal skin becomes gangrenous. So it becomes completely avascular and becomes gangrenous. So there will be sudden pain in the scrotum followed by gangrene, usually following trivial scrotal injury or minor operation upon the perineum or urethra. Treatment: wide excision and repositioning of the testis in the thighs. So you remove the all gangrenous scrotum, then keep the testis in the thighs. This is the testis. Of course, you can ask me, if you keep it in the thighs, what about spermatogenesis? So usually this occurs in past middle age or old age people. That is why by that time they should have achieved completeness of their family, so there is no need for any spermatogenesis. Then lymphangitis, etiology: filariasis, folliculitis. There will be painful erythematous and edematous skin of the scrotum associated with general features like fever, chills and rigor and tachycardia. Treatment: rest and elevation of the scrotum, antibiotics, DEC and analgesics. Elephantiasis of the scrotum. If the lymphedema becomes excessive, there will be fibrosis of the edematous skin and it becomes so much large. Causes filariasis, LGB. Treatment: wide excision and repositioning of the testis in the thighs. Cancer of the scrotum, etiology, the suit of chimneys. Cancer of scrotum also is called as the chimney sweeper's bottom. Shale oil, incidence unknown in India and Asia. Pathology, this squamous cell carcinoma. Treatment, wide excision. Clinical approach to scrotal swelling. First of all, you should check whether it is scrotal swelling or not. How do you check whether it is scrotal swelling or not when a patient comes with this swelling in the scrotum? It may be an inguinal scrotal swelling or a scrotal swelling. So, to know that, what you do is you do the test of getting above the swelling. This is how you do the getting above the swelling. You place your thumb in front of the scrotum. You place the index finger behind the neck of the scrotum, and you roll between your two fingers. If you feel only the cord structures, that means that it is a scrotal swelling. Then you check whether it is from the skin or from intrascrotal structures by skin pinchability test. Then check whether it is solid or cystic swelling. This is how you check. You keep your thumb and index finger on one pole of the swelling, and other hand, thumb and index finger at the other pole. You press these two fingers. If you feel a fluctuation wave felt by the other hand fingers, then that means that fluctuation is positive. So you do the consistency and fluctuation test. If fluctuation is positive, consistency is soft, it is cystic swelling. Then you do translucency test. You must have a pen torch and a tube like this. This is called transilluminoscope. This is not a very big instrument. Name is big, but instrument is very small. It is nothing but a opaque tube. So you keep torch on one side and look through the tube from other side. Do you know who is this doctor? He is Das, Surgeon Das, who wrote the clinical methods on surgery and who wrote the operative surgery. Of course, not the textbook of surgery. The textbook of surgery was written by his grandson. You should not keep the torch at the posterior side of the swelling, because testis will come in the way. So you cannot appreciate the transillumination. You must keep the torch only from the sides. These are some of the clinical tips you should know. So you can see the torch is kept from the side, and you can see the brilliant transillumination. Transillumination positive. Testis not palpable separately means it is hydrocele. Testis palpable separately. That means swelling is separate from the testis. It can be due to epidermal cyst, cyst of hydatid of the margagni, encysted hydrocele of the cord, and spermatocele. Cystic swelling, transillumination negative. It can be chylocele or pyocele. If it is solid swelling, examine whether it is from the testis or epidermis. If it is from the testis, you must make clinical diagnosis of tumors only, because gamma is rare. Clotted hematocyte also is rare. So if it is a solid swelling, you check whether it is from the testis or from epidermis. If it is the testicular mass, it is tumor testis. If it is due to epidermal mass, for example, see here, this is testis. This is the epidermis. So much swollen. So if it is epidermal swelling means it can be due to tuberculosis or non-specific epidermitis. Then examine the groin for any associated inguinal hernia. Examine the other side for any scrotal swelling because there may be bilateral hydrocele. Examine the inguinal nodes, abdomen, and supraclavicular nodes. Because testis drains to the para-aortic nodes, you must examine the abdomen. Examine the supraclavicular nodes because from the para-aortic nodes, the lymph drains to the varicose nodes. Then why inguinal nodes? The inguinal nodes are examined because they drain the scrotum. You are examining not only the testis, you are examining the whole scrotum and its contents. That is why you must also examine the inguinal nodes. Any doubts, please? Okay. If I have no more doubts, we will close the session today. Tomorrow we will discuss about hypothyroidism and parenchymatous goiter. Okay? Thank you. See you tomorrow at 4 p.m.